Hello, everyone. It's great to see everyone's faces. Welcome to our lunch symposium. Thank you. Please engage with us as you see on the slide. Scan the QR code. Welcome to our symposium, Building Momentum, an Unstoppable Force Against HIV Stigma. I would like to first acknowledge the land on which we are operating is the traditional land of the Huron-Wendat nations. Thank you for letting us learn and work on these unceded territories. So let's do a little bit of a self-reflection. I want you to ask yourself, have you observed implicit bias, stigma, or discrimination related to HIV in your surroundings? And how can you engage, spread awareness, and help address HIV-related stigma? So like I said, please engage with us. Scan the QR code. If you don't know how to do a QR code, please ask somebody at your table. Or go to slido.com and enter the code 2998139. We'd love to hear from you. You can participate in our many polls. And you can ask a question. Click on our Q&A tab to submit your question. This is our disclaimer. So first, let's introduce ourselves. My name is Maluba Habanyama, and I'm here from Toronto, Ontario. I work at the OHTN and wear many different hats in the sector. First and foremost, I'm a person living with HIV and have been my entire life, which is in 20 days, it'll be 30 years now. So let's start at the end. Dr. Lebouché.
Hello, everyone. I'm Bertrand Lebouché. I'm a clinician scientist, family physician, specialized in HIV care, and I work at the McGill University Health Center in Montreal.
Hi, Tansei. Tansei, hello. My name is Wapukwini. And I come from Treaty 6 territory originally, and I live on the unceded lands of the Squamish, Tsleil-Waututh, and Musqueam peoples, which I call beautiful country, not British Columbia. Because I've been there a long time. I've been almost 29 years. In December, it'll be 29 years living with HIV. And thank you for welcoming me here.
Hi, everybody. I'm Dave Miller. I work with ReachNexus, and I'm from Mi'kmaq territory on the East Coast, and I've been living with HIV for 14 years.
And good afternoon. I'm Sharon Walmsley. I'm a clinician scientist at the University of Toronto. I'm the director of the Immunodeficiency Clinic at the University Health Network. I'm co-director of the Canadian HIV Trials Network. And I have been involved in care and education and treatment of people living with HIV since before Maluba was born.
These are our disclosures. And I want to look at our first cloud, which is what does stigma mean to you? So I'm seeing a lot of themes of discrimination, ignorance, rejection, isolation, exclusion, shame, barriers, negative thoughts. So thank you for participating, and these will keep on going around, and we're taking that feedback. So our objectives today are to discuss the broad-reaching effects of HIV-related stigma on the health, quality of life, and care of people living with HIV. We'll get into how these different types of stigma, and we'll identify them, and how this can impact people living with HIV in order to assist people living with HIV in mitigating or overcoming the effects of HIV-related stigma. Today's program is centered around healthcare provider reflections. We'll have a panel discussion with our community experts, and to get the ball rolling, Dr. Walmsley will take us through stigma and its impact with people living with HIV. After a brief audience Q&A, we'll build momentum with Dr. Lebouché and the panel discussing on how we can integrate an experience of the experience of stigma and its identifications into care. To close, we'll all share some calls to action and hear your calls to action and take more questions. Sounds good? Well, great, because you don't really have a choice. All right, I'm going to hand it over to Dr. Walmsley, or Sharon, excuse me, and to learn how far we've come and how far we have to go.
So thanks very much, Maluba. And I've been asked to kick this off as the person on the panel, having been dealing with this for over 3 decades. And I think all of us in the room know that stigma is still a huge issue as it relates to HIV. And often we think we haven't gone anywhere, but I was charged with reflecting a little bit about the past and the fact that we have made some steps. So I can remember back as a young intern having seen the first cases of HIV in the city of Toronto. We didn't know what this was, and of course everybody was afraid. So people living, we didn't even know it was HIV because we didn't have HIV, but people who were thought to have this infection in hospitals were put in isolation rooms. Everybody went in the room with full glass, masks, gowns, bleach. Sounds like COVID, eh? Their meals were left at the doorstep. It was pretty horrible. People refused to do invasive techniques on patients that may need it for fear of their own contagion. And I can remember when we were trying to deal with people that we thought had pneumocystis pneumonia, trying to get the respirologist to do the bronchoscopy test we needed, and they refused until I threatened to learn how to do it and take away their income. I can remember fighting for the first patient in our hospital who needed a kidney transplant. No, people with HIV can't have that because they're not going to live. And then the early days of the markers of disease, and everybody remembers what some of those earlier HIV medications did to people. And you could walk down Church Street in Toronto and know who had HIV because of the buffalo humps, the lipodystrophy, the Kaposi sarcoma on their faces. People were not allowed to work as healthcare providers because there was concern that they were going to transmit the virus to their patients. People couldn't travel anywhere, and I can remember telling my patients, don't even put my business card or your appointment card in your wallet because you're going to get stopped at the border and not be able to go. And people who were potentially at risk of HIV were not allowed to donate blood. So we have gone somewhere, okay? And I think one of our big victories, and which we see at this and many conferences, is the concepts of GPA and MIPA, involving people with HIV in a meaningful way in all of the work that we do. And this whole concept that we've been discussing today and over this conference of U equals U, who could have imagined that we were able to achieve that goal? And people living with HIV now can enjoy long-term survival, provided that they have access and are able to take the necessary medications to treat them well. I think one of our greatest victories is in the prevention of vertical transmission. And to be able to tell my women over the years, yes, you can have a child and your child will be free of HIV, has been tremendous. We've been able to come up with safe injection systems to allow people to inject safely. And then some of our pharmaceutical advances, who would have dreamed that one pill once a day would keep someone suppressed? And I can remember in the early days, my patients coming with their bags of pills and their beepers and their timers, having to not miss a drug. And now we have the injectable antiretroviral drugs, which are great for some people, not having to think about taking that pill every day. But we're not there. We are definitely not there, and I think all of us recognize that today, and there are many issues remaining with regards to stigma and discrimination. And the public and the healthcare system needs to have some continued public education about HIV and where we are at today. We had some discussion this morning about decriminalization. We as scientists all believe in the U equals U phenomenon. Why do the courts not? What about insurance? People have normal life expectancies. Why can they not get life insurance? This is crazy. And I deal a lot now with people aging with HIV, and now we're having to face some of these issues all over again as people go into long-term care and often have to disclose their HIV status all over again and be treated by healthcare professionals who had nothing to do with HIV and dealing with all of those challenges again. So stigma comes in many, many different ways. That stigma may be in the individual themselves, that they have internalized negative feelings about having had HIV. I think there are many stigmas associated with treatment in the healthcare systems, and we certainly recognize that when we refer our patients to different specialties and the way in which they are treated in some of those clinics. But there may also be either perceived or anticipated stigma, that you think that somebody else is going to treat you differently because of your HIV. And then there's the actual discrimination of how you are treated by others. And there are many potential external sources of HIV-related stigma. Some of them are in the social or public arena, some of them in the healthcare stigma. In the social media, the negative stereotypes that go along with somebody living with HIV, that maybe this is socially unacceptable, or people saying they deserve to get this because of their lifestyle. But this results from a lot of fear and misconceptions in the general public and many moral judgments that they are making. In the healthcare system, I see it still today, that people living with HIV may be denied certain care or being forced to go and get testing before they can have that care. And perhaps the treatment that's being offered for them is conditional on some sort of activity, such as taking contraceptive or some other restriction. And clearly, and I see this all the time in patients who come to my clinic who've had some sort of problem that's, totally independent, but the message that they always get, oh, this is because of your HIV, this is why it's happening to you. And that sometimes people living with HIV have different treatment recommended for them just because they have HIV. And again, I reflect back on a lovely woman I took care of many years ago who was denied life-saving treatment for cervical cancer because she had HIV, and they treated her with radiation therapy instead, and she died of that illness, and that was totally unacceptable. But people who live with HIV also have a lot of intersectional stigma and discrimination. So it's not just the HIV, but there are these intersecting bubbles that create stigma from many different directions, which may include their ethnicity, their socioeconomic status or employment. We've heard a lot about migration, their mental health or substance use, their sexual orientation or gender identity. And now, as people living with HIV, they get into ageism as well. And HIV-related stigma can have negative impacts on a person in many different ways. It may impact their mental health, it may impact their physical health, or other aspects of their quality of life. So certainly we all know that stigma can cause emotional distress, a negative self-image, shame that many of you put up on your bubble today, and that leads to a lot of fear of disclosure for fear of discrimination, and then often leads to isolation, depression, anxiety, or even a risk of suicide. I see it in the physical end of people's health, and there's certainly lots of evidence in the literature that stigma can result in poor outcomes, largely related to stress and inflammation, but can also have detrimental health on disease progression. There can be care gaps, not only in physical health, but also in physical health and psychosocial health, but we all know that this can lead to barriers to adherence, and this can also lead to bad outcomes. But furthermore, stigma can affect quality of life. It can affect your life satisfaction in many different ways, and can have impacts on other aspects of people's lives, including travel, food, security, employment. And I can't emphasize enough that adherence to antiretroviral therapy can be particularly impacted by HIV stigma, and this is just data from a systematic review of a number of studies in many individuals, and this is clearly something that can impact a person's ability to take their medication on a regular basis, achieve that U equals U, and achieve that long-term survival that we all hope for. This is a research meeting, and I think we all need to remember how we can involve people living with HIV in our research, the importance of the GIPA and the MIPA philosophy, and think about your own research and how you might engage people meaningfully in your research. And that stigma, or dealing with that, can help them eliminate some of that stigma and feel valued within your research. So they're just not that checkbox on the CAHR application, yes, I have community. Please involve them, and that is going to help at many different levels, one for your research and two for their well-being. So GIPA and MIPA does help address stigma. Empowerment can improve mental health, improve self-esteem, and reduce a sense of social isolation. And public acknowledgement can help eliminate stigma and discrimination at many, many different levels. So I'm going to turn the stage now to my colleague, who's going to talk about the Stigma Index.
Thank you very much. So I'm the Atlantic Stigma Index Coordinator through ReachNexus. We just wrapped up the study after a few long years in Atlantic Canada. But this Stigma Index study is amazing in that it's for and by people living with HIV. And it's about building a network of people that can relate to each other and share stories. The HIV stigma is alive and well, and it affects people living with HIV in different ways. The protective factors such as resiliency, social support, self-efficacy, reduced levels of stigma, we know, and increased number of health risks contribute to a higher level of stigma. We'll be reporting that back at 3 o'clock in the next room, if you want to hear that. That's my plug. So I'll turn that to Dr. Lebouché. Is it over to you? Oh, is it back to you?
Is it back to me? Okay. Okay. Okay, so we want to have another of our polling questions, so get out your phone. Again, if you don't know how to use these, find a teenager.
A millennium.
I never know how to do it. So think about your research that you're doing. Do you address stigma as part of the research you do or part of the research you participate in? So please answer our question. No, we've done something wrong. Oh, there we go. Ooh, the moving lines. I feel like I'm at the disco. All right. So we've got about a third saying always, we got a third saying most of the time, 20% saying some of the time, and 13% rarely or never. Those are the ones we want to work on. But I think, think about it. Even if you're in basic science, even though you're working with a test tube, there's still a way in which you can think about stigma as part of your research and think about the impact of your research and how that may impact stigma down the line. I think we have another question. Okay, next question. Get your phones out. Does your organization have policies, procedures, or guidelines related pertaining to GIPA and MIPA? So I think from this poll, it looks like our organizations are doing a little bit better than we're doing as individuals. We hope that our organizations are including this. But I think, again, we still have a number of people in whom this still can be addressed. So I think that we're hoping to give you some more ideas and concepts as we move along in this symposium.
That was great. Thank you for participating in that, and thank you, Dr. Walmsley, for that great presentation. It was very enlightening that a bunch of people did say they're not sure if their organization has these guideline procedures. And so I think that's that question of we need to find out if we have those guideline procedures and if they're being followed, because a lot of the time something can be on paper and it's not necessarily being followed. So I'd like to ask our panel, Dave, what experiences or what is your experience with HIV-related stigma within the healthcare system?
I can tell you, after my diagnosis, I was hospitalized for mental health reasons. And so I went into the hospital seeking help, obviously. And I was labeled as a biohazard. That was the first thing put on the door. And nobody said anything, but I knew as a person living with HIV that that's what they were referring to. And, you know, that was tough because I put that stigma on myself at that point. You know, I'm causing all of these issues in the hospital. People don't want to come into the room, and ended up leaving the hospital feeling worse than I did when I went in. So it's a huge issue for people, and a lot of the reason why I do the work that I do now, to make sure that people don't have to experience those things today.
Thank you. Claudette, same question.
I try to limit my exposure to the healthcare system because of historical trauma and discrimination. A recent example is when I had to go get my blood work done at a different clinic because person at the first clinic that I usually went to was rude and told me conflicting things. I had to wait this is what he said, I had to wait really long because at that one place you had to go online, and I barely do anything online because it's just kind of sketchy sometimes. And so I said, no, I didn't do that. And so he said, oh, you're going to have to wait a long time, and you go in this other room and wait. And I didn't end up waiting. I just walked out. I had fasted for 12 hours, and when I'm in that condition, I'm ready to have a meltdown. I even had called the phone line and the doctor. She's like, are you having a moment? Yeah, I'm having a moment. Do you need 911? Oh, you're going to need 911 soon. It's asking me. It's that. You're in a different mindset when you think your lab requisition is getting faxed down to the lab, and it wasn't, and I just exploded. So if I don't have to go, I won't. And yeah.
I relate to that, actually, both what you said. I stay away from the healthcare system if I can. Just as a child, I remember being with my mother where we would go to walk-in clinics, and as soon as they learned that my mother and I were HIV positive, they would give her a look. And I would see my mother try to they wouldn't even ask, but she would start to explain, oh no, my husband wasn't faithful in our marriage, and he gave HIV, and she would explain this whole story, and so I watched that stigma. And when I was 19 and I moved from Oakville to Mississauga, something must have happened in the system where it came up as a new diagnosis in Peel Public Health. And so they called me to come in. And I remember this woman said, oh, you need to sit down, you need to tell me your sexual partners, you need to know this, you need to know that, and really just talk down to me. And when I explained to her that I was born with it, she said, born with it, and actually did not know that you were aware you were allowed to be born with HIV, and it was something that I had to explain. Mm-hmm. And then when I was in the emergency room one day with my sister, also in Peel, they couldn't take me in, and I ended up fainting right in the emergency room. And when they put me on the bed, they said, oh, this patient is 20 years old and is HIV positive, right in front of the entire emergency room. And my sister was also with her boyfriend at the time, and that boyfriend did not know that I was living with HIV. And so they exposed my status to this entire room, and to people that did not know. And so since then, I've been scared of the healthcare system, and I've always just gone to my HIV specialist, not wanting to go to family doctors, not wanting to go to dentists, and it traumatizes you. So what's your experience, Claudette, I'm going to start with you. What has been your experience with HIV-related stigma outside of the healthcare system?
Outside? For me, I want to share something I wrote on my daily experience of aspects of my life. Is it this one? Is it? I can't remember. It's the book, right? Okay. Thanks for that. So I work at the BC Centre for Excellence in HIV and AIDS in beautiful country. And we had this exercise. We used to do a Nelson huddle, it's called, and we used to meet up, and we practiced everybody's presentations and stuff that the center's working on. And the topic that my peers in that were presenting on was stigma. I said, oh, this is just perfect. And then stigma, what it means to me, it's in my face every day. As soon as I walk out that door, I'm judged by the way I look. Persons look at me as a street stereotypical Indian They give me the condescending up and down look, like, mm-hmm. And therefore, I am a thief and followed in almost all the stores that I enter, because even at my local grocery store, there's this mystery shopper, and I'm like, yeah, I can spot him. I'm like, I can outrun you in the store. You go that way, and I'll meet you this way. And I'm like, yeah, I walk right up behind him, you know. And then it's next to being heard, a lot of belittling behaviors I experience. It stirs up a built-up anger to use in a constructive rebuttal and throw that back in your face, feedback to educate the insult and how it makes me feel for what you're saying to me.
Thank you for sharing. I think for me, if I go back to my childhood, when I was about 7 years old, I had a big sister out of the Big Sister program. I had a mentor, and when I went over to her house, her and her husband got to eat off of glass plates and gave me paper plates and paper cups. So as a child, I was already seeing this stigma occurring in front of me, and I think that in turn, a lot of the stigma that I experienced outside of the healthcare system was in my own. It was a lot of that self-stigma that we talked about and that internalized stigma. Dave, I'm wondering about what HIV-related stigma you've seen outside of the healthcare system.
Try to think of which experience. There's so many of them, but and this is not years and years ago. We're talking 14 years ago. I mean, we've done a lot of work. We still have a lot of work to do, but I remember thinking back around disclosure and how in the beginning, how difficult that was to disclose to people. And so one experience was an online application. I won't say which one. You can guess. But I remember having my profile picture shared among everybody else that was in the area with the disclaimer saying, watch this guy, he's got AIDS. And that is a hard thing too, because, around disclosure, that one piece, that's hard enough for yourself to disclose. It's even harder when somebody else does it for you. It takes away that power. And so that was one experience that was tough.
Thank you for sharing. And I think it's very important that we do talk about stigma in the healthcare system and outside, because that's what gives us this view of life. And I, at 16 years old, where I'm just starting dating and just starting liking men, and my mother, she had married somebody, and then they were going through a divorce, and then he had charged her with non-disclosure and said she had not disclosed her HIV status, and although in those law papers also disclosed my status. And so I had watched my mother go through this court system and go through this trial of having to explain her HIV status. And so as a young girl, a 16-year-old girl, that I'm realizing, disclosure this is something I could go to jail over, and I was traumatized by that as well. And so I want to open up to audience questions. Please ask your questions within this Slido app. There is a question tab, and I'm going to open it up and see. So Dave, we do have a question. Were there any differences in the results across Canada for the HIV stigma index?
So we've just wrapped up Atlantic, so we're just starting to look at that data now. And again, we'll be reporting that back at 3 p.m. But there are a lot of, this is my second plug. Sorry, Viv. There's a lot of similarities across. Like we just re-implementing in Manitoba and British Columbia with an updated tool. So yeah, lots of similarities, but there are some differences.
Thank you. Oh, I like this question. It's why was HIV stigmatized in the first place? Is it because the science diagnosis was wrong by saying it's a sexually transmitted disease from many sexual partners? That's a great question.
So I think the stigma at the beginning is started off by the epidemiology of the infection. So I think the epidemiology of the infection at the time was primarily men who have sex with men. If I remember now, it was Haitians and hemophiliacs, right? And so I think the stigma started by marginalizing people because they were in risk groups. I think a lot of the stigma in the hospitals was fear. And I think everyone was feared. There was concern that this was a bloodborne pathogen and that by doing your job, you were at risk for this. And I think that's where a lot of the stigma in the healthcare system came. And I think, as we're talking further about the call to action, I think there are many physicians in the healthcare system that still don't get it and still don't understand that the advances that we've made in terms of this disease and that, no, you're not going to get it by walking in the room, you don't need the biohazards on the door, that persons living with HIV should be treated in the healthcare system like anyone else.
Thank you. And I'm going to go to one last question, but you guys are asking a lot of questions. These are great. We're definitely going to get to them. How can researchers work to create a more inclusive space for people living with HIV?
Oh, there is a lot of way, I think, to do that, but possibly is to really to invite and to include people living with HIV in their research team. And even to ask people living with HIV to become researchers with them and to share their double expertise, living expertise and research expertise. So I think it's a good way to do some research, and it changed a lot because I think really the idea is to try to answer to people living with HIV question with our research, and not only to a researcher question. So I think that's really important. And if we are in a team and we have several, it's really interdisciplinary and everyone shares several experience, it's really interesting and it could be a good way and it's relatively natural after.
Yes, absolutely. I agree. It's consulting with people living with HIV from the beginning of your research project. I think there's so many times that I will get a request to join a community board or give some input at the end, or when they're in the middle, they've already gotten funding. I think it's really important. A lot of the times we're looking at this research question and we decide what the community needs. But have you asked the community if they actually want to know this question, if they actually want these results? I think it's very important to do it from the beginning. So I am going to hand it over to Dr. Lebouché to talk to us about Lina.
Yes, so let's go to practice, to the clinic. And I want to discuss with you how we can try to integrate the negative consequences of stigma in care and how we can evaluate that, assess that, and if it can give a real consequences in our decision in HIV care. So let's listen to Lina. So just want to start with very interesting data for the positive perspective study. I didn't remember, it was presented at CAHR previous years. It's an international survey with more than 2,300 people with HIV who answer questions about their experience with their antiretroviral therapy. And it was very interesting. It's very recent data for 2019 and 2021. And really what was interesting that if we ask them, 33% feel very stressed and anxious about remembering to take their HIV medicine every day. And for 29%, they perceive art as a negative impact in their daily life and can limit a bit their daily life. And more than 50% feel that taking art is like a daily reminder of their HIV status. So let's discuss with Lina and let's listen to Lina. So Lina is one of my patients living with HIV. She's 43 years old. She is living with HIV since 2006, when she was diagnosed. And she has a very difficult and, as she explained to me, a chaotic antiretroviral history until she was with dolutegravir, 3TC, and abacavir in a single treatment regimen. She had more than 10 different regimens. It was difficult, always difficult for her to maintain undetectability, to reach undetectability she can. But to maintain it was very difficult, particularly during a pregnancy. We have to, even together, we have to fight. And she succeeded, and I succeed with her. So that was good, but she stopped the day after the delivery. And she is periodically detectable, but she always has the same CD4 since the beginning, around 387. And she's very regular, almost regular with her appointment, just sometimes she postpones. And I ask her, I ask her two things. I ask her, do you want to test? Because we are developing a new patient-reported outcome measure, the I-score for interference score, and we have a new patient portal. And do you want to test it? It's a pilot, it's a CTN pilot study, and do you want to participate? She said, oh yes, I want. Okay, do it. And I asked her a second question a bit later, can I share your story? And she told me, yes, you have to share my story because you train your colleague clinician. So, okay. So I will do it. So what is the problem? The problem is patient-reported outcome measure. So is that a questionnaire most of the time, and is really to catch directly the patient perspective, the patient evaluation of their care. So it could be patient-reported outcome measure or patient-reported experience measure to evaluate also their experience with their care. And it's not really used, actually, not widely used in HIV. It's used in several chronic conditions. And with my team, since 2016, we are developing the 7-item I-score for interference score, and it's I'm happy to share that with you, but it's not only what I did, okay? So I did that with Kim Engler and David Lessard, my research associate, and also with Serge, who is here, with Dominique, with Anish, with Joël, with Edmundo. So really, I think it's a team, it's a teamwork. So I want to, because it's important at CAHR not to forget that we are not working alone, okay? And it works because we're in a team. So the 7-item I-score, really what we wanted to do, we wanted to see if antiretroviral therapy can have a minimal impact in the daily life, okay? But to do that, we have to ask people we take this antiretroviral therapy. So that's why we develop for several years. It's a long process, and we try to do like an index of perceived difficulty to take antiretroviral therapy. So it's not a measure of adherence. I don't want to ask, do you take your treatment or not? No. But I want to ask, in the last 4 weeks, in these several areas you can see here, do you think you have some concerns that make it difficult for you to take your treatment? Okay? So it could be before problem of adherence. So you can see what we have. We have soaked on feeling. So it's about acceptance of having HIV or habits and activity. It's about how to integrate your treatment in your daily life. Social situation, particularly we have stigma, and we have also the social, if you are alone. You have also economic situation, housing problem, financial issue, your health with viral load, CD4, symptoms, your medication, the size, the taste, how you have to take it, and your care. So your what is it with your healthcare provider, with your pharmacist, if you have to pay. So it's a lot of potential area of concern. And what I forgot, and we ask for a barrier. So it's like a Likert scale. So when it's green, 0 is no barrier, 10 is maximum barrier. So Lina, she receives Opal is a patient portal, so really she has access to everything. She has access to her blood test result. She will soon have access also to the note of the doctor. She will have access also to change her appointment. So, and it was developed by a a patient who had a breast cancer. So it was developed originally for cancer patients. She was a famous IT researcher at McGill. Sadly, she passed away a few years ago. And really, she wanted to do for patients. So the patient portal is not done for the clinician, is not done for researcher, is done for patient. So you can see for us, what we did, we adapted for HIV care. So with Opal Health, so you can see what Lina saw when she has to fill the questionnaire. So she just has to answer to the 7 questions. And what is important also, that at the end, she can see the result, so she can do like a self-evaluation. So what does it mean? So you can see here, I will come here, it will be better for me. So you can see here, it's a several, she has a visit almost every 3 months. So you can see here what is important for her with high barrier is the emotional impact of HIV. She always feels rejected because of her HIV diagnosis. And also in her social situation, she's very isolated. And I didn't know that. I learned that thanks to the I-score. I didn't know that she's almost alone with her daughter, and they go out to the park to play together, and that's it. She only has 1, 2 friends, but it's work friends. And after her economic situation, even she works as a nurse assistant in an hospital, is always a problem. And she experienced some discrimination in her hospital, and she's not very well paid. So it's always a concern. She's scared to have difficulty, and she's alone with her daughter, and she's always a bit concerned also to have to pay for the co-payment for the antiretroviral therapy. And also there is a pill size, for sure. She is with dolutegravir, abacavir, and Sweet EC, and it's a big pill for her, and she has really difficulty to swallow it. So she can see her pill. So that's a huge problem, and she has also the pills fatigue. And you can see here with her care, sometimes really it depends. Even she have access to a specific card, so she can be helped for co-payment. It's always a concern. So periodically, it happens. So what is interesting, it took 3-4 minutes to Lina to answer to this question, because she told me, yes, I need time to think about it. And what you can see here is what I have on my dashboard. It takes for me 1 minute to see that and to discuss with her what happens and what we can do. So we did that several times during this pilot study. And during the second evaluation with the I-score, she asked me that. Hey, doc, I heard that there are some medications so you don't have to take every day. So can I have this? Can I have this medication? I was not really comfortable, because she is not fully undetectable, and normally the indication is if you want to use long-acting treatment with cabotegravir and rilpivirine, you have to be undetectable. So I was not really so comfortable saying, yeah, let's think about it. And she told me, no, let's talk about it, she answered to me. So I have to think and to talk about it, okay? And so what will be your treatment decision for Lina? So you will not vote, but you can think about it. So I told her, okay, you have a problem, so we have several solutions. I tried to escape a bit, okay? So we can change for dual therapy. The size of the pill will be a bit shorter, so possibly, no. Okay, so we can change for bictegravir, TAF, and FTC. So it's another single treatment regimen. It's something similar, but it's a smaller size also. So possibly you need to change. And the last question is, do we have to accept really her demand? It's a strong demand to go to long-acting. So you can think, and in the response for answer A, B, or C, she answered, Doc, the injection are really going to help me. I can't stand with my HIV, and I can't swallow the big pill. If you don't give me them, so the injection to me, I will stop taking the pills. Okay, so I discussed with the pharmacist in my clinic, and we decided to answer to her demand. So what I learned about Lina from the I-score is the pill fatigue, and we can evaluate. That's what is interesting with the PROM. You can evaluate, you can assess, and you can see, because it's interesting for her, if she has a problem in this domain, most of the time she will stop the treatment. You know, it's not the case for everyone, but for it, every time she stops the treatment if it's too much. So you have the pill fatigue, you have the pill size, you have also increased barrier that led to hard discontinuation, as I told you. So really, it's a big concern. That's why she was several times on and off antiretroviral therapy. Also, she's very motivated. She doesn't miss her appointment. For me, it was really an important aspect to be sure she will go to the injection appointment. Also, she's hepatitis B immune. She doesn't want to get pregnant. And actually, she told me, it's okay, I have a daughter. And we have a multidisciplinary model of care with very strong and efficient clinician pharmacists. So I know that I'm not alone, and we will find together a solution to answer to her needs. So I think with that, I just want to see, with this PROM, but also with other PROM, it's important because we can assess the negative consequences of stigma, and you can see that everything is linked. It's not stigma alone. In stigma, we can have consequences also on the difficulty to take the treatment, but also difficulty to go, why not, to the healthcare facility. So everything seems connected, and you can assess that, and you can assess objectively. So I can see the evolution, you know. And it's interesting because it's a switch of the paradigm of adherence. Adherence is not to take the pill every day, but what she wants with the long-acting is more to be, she needs to be adherent to the injection appointment. So it's interesting, and we have some benefit, no pill fatigue, no tablet, for those who struggle to swallow. But for sure, at the same time, she accepts to have more appointments, so to come back more frequently to see an healthcare provider. And also, something important for her, privacy-reduced stigma. So I think it's something also important for her. So monitoring with PROM, to go back to PROM, so patient-reported outcome, I think it's important because it can complete the usual follow-up, you know? And also, what is important is I can really integrate what is important for my patients, and I can integrate this priority, her priority, including the stigma consideration. And it's not so easy. And if you don't include that, it will be like an underrated problems. And you can also quantify the patient perspective. So really, it's important. It's like an objective measure. And as a clinician, we need some objective measure. And it could be used also between follow-up, because I can send her like a text, and on the patient portal Opal, she can answer. So even she doesn't want to come to see me, I can, okay, just answer the I-score, and after I will call you. Okay. And also, I think it saves time. For me, for her, it takes 1 to 3 minutes. For me, it takes 1 minute to evaluate, and I know a lot of things. And I don't have a lot of time during my clinic. So, I have a question for you. Would you be interested in using PROM, patient-reported outcome measure, in your HIV clinical care?
Get back
Okay.
into that.
I'm not sure I convince you, but I'm happy. So now that's what we have to do. I think.
Bertrand, I already do. That's a little disconcerting for you.
Exactly, you're right. So, you know, we really have to, it's time to go to action and to try to integrate. I know that we have to go slowly, but really there is a lot of possibility, and don't hesitate even to ask my team. They have a lot of idea how to integrate PROM in your daily practice, and really even for people with HIV, really to push your clinician to integrate your perspective with this PROM.
Thank you. So there were a lot of questions, even on Slido, about this, and so I would like to ask all of us, how can healthcare providers and researchers step up to identify and counter stigma? I think for me that I've noticed is a lot of the times people living with HIV, they have lives and they're not always going to bring up stigma to their doctors. I'm not going to tell my doctor when I am having problems with adherence, it's dealing with stigma and dealing with another thing happening in my life. And I think having those conversations and bringing them first and foremost, it's very important for healthcare professionals and researchers I found with my healthcare providers when they can help me advocate for myself and when they can advocate for me as well. I think that's so powerful because sometimes people living with HIV and activists are always expected to advocate for themselves. And I think a lot of people in the room can relate to sometimes HIV activists make the worst patients. I know that works for me. And I'm very good at advocating for others, but I'm terrible at advocating for myself. What do you think, Claudette?
For me, it's very important to understand the intersecting experiences we have, view stigma how we experience it. And I think, is that my slide or I'm reading the wrong one?
I think we'll go to you.
Okay, yeah. Yeah.
What do you think, Dave?
Continue to work with community as you are, and also we just had a discussion the other day with at a conference around the healthcare professionals are usually the first ones that see the research, that are aware of the studies that are going on. Mm-hmm. And it would be so much easier if they all would sort of promote that and say, look, this study's going on, I think, might benefit you. Because then that helps us out as researchers going out and trying to promote it. But if they get it, from the horse's mouth, it'll make it a lot easier.
Dr. Walmsley, you mentioned how we've come so far, like we could do one pill once a day. However, stigma is still very pertinent. And so how do we address that where we're not, we're accolading that we've come so far, but we're also realizing that people living with HIV are dealing with daily stigma?
Yeah, well, I think, something that Claudette mentioned, it's the unconscious biases. And it's that look, it's the way you're treated, it's the chair you get, it's the paper plate. It's these things that people do and they don't realize the impact that may have on someone else. And so, we're preaching to the people that understand this and deal with this, and we deal with this in our clinic in a positive way. But it's how do we get beyond the HIV clinic and get into the primary care, into the specialties in our hospitals to understand the way we went. And I was mentioning this morning, I got this call just last week of a trauma surgeon in the transplant unit who was doing a procedure on a patient living with HIV who was undetectable, had been undetectable for forever, and had spilled blood on her gown that soaked through to her gown to her pants. And did she need to go on post-exposure prophylaxis? And I was called by an infectious disease physician to ask this question. I was horrified. And so, if that in the ivory tower doesn't understand this principle, we have a lot of education to do. Yeah.
Dr. Lebouché,
I think sometimes it's not easy to try to assess these negative consequences of stigma. It's not easy because a lot of clinicians, they don't have time. Because there is a lot of people to see during the clinic. So sometimes we have 10 minutes, 15 minutes. And can we open the box, of the stigma in 10 to 15 minutes? So and I think when you have the chance, like me, to work with a big team, with several healthcare providers, with nurse, with social worker, with psychologists, so even people at the front also, you can, sometimes they will, my patients, they will discuss with people at the front and will tell me, don't remember, he told me to tell you that, he has this problem. So it's helped me, because the clinician can do it. So it's important, and that's why really I push that we have to assess that systematically. That's why you have to use patient-reported outcome, because it needs to be integrated. Otherwise, it's almost, I think it's impossible because we can spend 1 hour per patient. It's impossible, actually. Right. So that really we have to find a way to do it, and we can discuss that, and we can try what we can improve together and what is, but it could be for next time, it will be a bit more difficult, or we need the help for a community group or something like that. So,
Yes.
but really, we need to integrate that as a viral load, as a CD4. For me, it's similar outcome, and it's really important in HIV care.
Yes, absolutely. You brought up something great, getting that community help. I don't think it's a one-size-fits-all. It's a
Exactly.
one healthcare professionals, researchers, community workers, and they're all separate. We all need to work together in order to address and hopefully eliminate HIV stigma. I'm going to pass it on to Claudette.
For this slide, I just want to honor where this comes from. It's from the late Hesham, and this really spoke to me when we presented with the Thrive team and the Fraser Health. That's how I feel, all out of whack when my physical body and everything is that. Think of when you're doing like the hula hoop, and then it spins around and it's going in all directions, and that's how it feels my whole body. The labeling, the power struggles with the higher ups that think and give you that condescending looks, the social exclusion. Yeah, that's why I don't go to the hospitals, seek treatment, but I do have a nice doctor that's pretty cool. He's pretty hip and young. So I gave him that grace in saying, all right, and then he said that because I know my body, and to have that validation that an actual male's listening and a young one. I had older doctors, and I'm like, I fired them, and I'm like, you don't listen to me, so I don't need to be under your care. And the discrimination, it's like every day. The stereotyping, every day. The labeling, every day. And it's just a constant, okay, how's it going to be today? And then walk out, and then some people are nice, then you get this, and keep going like this, and then it's like too many negativity in my aura. Then I go to nature, and that's how I unbalance all that stuff that's going on that makes it like you're like, a little bit like losing your glue. I call it glue. Losing your I have code words for certain things, and that's what I mean is like you're coming unglued, and you just have to center yourself, and you center, like it's right there. You center yourself in that stigma, and you go in there, and you deal with it, and you come out, and you go and do what grounds you, and keep doing what you do. Hey.
Thank you for sharing. Thank you very much for sharing. So now it's time to call for calls to action. Like we were saying, we know stigma is a huge problem. So the room wants to know, what are our calls to action? Dave, I'm going to start with you.
At the end of the day, I'd say we all just want to be loved, and we all want to go home. And unfortunately, that's not everyone is able to experience that. So I think we can all do our part. Here it comes again. If you see the stigma index in your area, get people involved, introduce it to them, because this project, this study, is going to bring out a lot of important information that's going to help everybody in the end. So get involved.
Dr. Walmsley, what's your call to action?
You know what? I would love to see a day when we wouldn't have to worry about disclosing HIV status.
Yes, I would love that. Dr. Lebouché, what is your call to action?
I think I will invite people with HIV to become researchers, because really it will be so helpful. It's always the case, but it's already the case. But we need to continue and to intensify this. And I want to invite you this afternoon to go to the CTN postdoc symposium, because Serge is a CTN postdoctoral fellow with me, and he will present his experience as a researcher living with HIV. So really come to, because I think it's important, possibly it will give you the the idea also to become a researcher, and he will also present tomorrow morning for the clinician session about the I-score and some data about the I-score. So just some advertising.
I love that. Encourage people living with HIV to become researchers.
Exactly.
And Claudette.
But I would like to echo everyone coming to the CTN Fellows presentation, because that's where our new researchers are coming, and that's where community can help us ask the right questions. So please come.
Yes. Claudette, what is your call to action?
We need to continue to educate everyone, no matter who you are, with HIV or without. Whatever your walk of life is, step up. When you see stigma or discrimination, stand up and help address it. Hi, hi.
And finally, my call to action, the theme for CAHR is the boomerang effect. We went from COVID-19 and back to HIV. And it'll always come back to HIV, but we have to understand, I'm not too worried about the people in this room. I do think that we want stigma to be eliminated, but what's going on with the people that are outside of this room? How are we reaching them? How are we talking to them about HIV, educating, not dealing with HIV stigma, not allowing it in any space? It does not live here. And I think that's so important. When we leave this conference and leave this room, how are we taking this into our real world and our work and our lives and how we can eliminate HIV stigma? Because we are so advanced in HIV stigma now. We're to a point of injectables and to one pill once a day. But we see with HIV stigma that it still is stopping people from living their truly healthy lives. And so I would just say, please think about how you're going to take the knowledge that you are using in this symposium and in this entire conference, and how you are going to take it out into outside of these doors. Now we want to hear from you. What is your call to action? Please share on the Slido slide. Unfortunately, we won't be able to share them all on the screen, but you could also leave your contact information if you want to receive all the results from the Slido slide. I'm going to open it up again for questions. We do have 2 mics on either side of the room. If you have any questions, please come up to the mics, and I'm also going to take questions virtually from our Slido slide. So do you see we already have lineups. We already have lineups, which is so exciting for questions. I am going to ask. I know we all can talk a lot in this room. It's going to be a little brief, but please, yes, go ahead.
Yeah, thanks, Maluba. Hi, I'm Ryan Peck from the HIV and AIDS Legal Clinic, Ontario, HALCO. I would like to add a call to action for folks in this room to urge the federal government to engage in criminal code reform to end the overcriminalization of people living with HIV. There's a lot that scientists, clinicians, researchers can do, and currently there's an open letter going around. So I really deeply encourage people to get involved, and at the very least to sign the letter. Thank you.
So this question goes to Dr. Boucher and maybe Sharon Walmsley and anybody else here. Your call to action was to encourage people living with HIV to become researchers. Big, big thing. What are you doing to create that space for people living with HIV to become researchers?
I think we start to create that space by involving community in our research. So I have community advisory boards with every project that I do. We involve people from the get-go, from when we start asking the research question. I've had them help you write the proposal and the grant. I keep them on the grant. And then when we have a hiccup, like we had with our project this week, we call them all back to the table and say, okay, we've got this hiccup. How do you think we best approach this? So I think by learning how we do research, I think that's one of the first steps. I think you can't do research from square one. You need a mentor. You need someone to support you. You need somebody to help guide you along the way. But by getting involved in these teams and by able to help ask the questions that are crucial to the research, I think is a great way to get involved.
Yeah, and I think what I said before about the double or triple expertise, I can just say about Serge is also a statistician, and he's a very good pedagogue. So it's excellent to. So my students, they come just to see him to understand what they have to do with their data, you know. And at the same time, sometimes they, oh yes, but me as a patient, I think this is weird, you know. So that's what is interesting always. So he's not only here as a person living with HIV, he is also as a statistician, he is here also as a nice guy because he's a funny guy also, so he's good into the team, for sure. So, and I think it's really important to mix this expertise for a very good integration. I want to be sure.
No, I think it's very important when, I started off on being on community advisory boards, and I think it's very important for you researchers to also identify that, are you always calling the same people to be on these community advisory boards? When are they transferring to becoming a peer researcher? And I also have a little bit of an issue with the name peer researcher because that just identifies that they're living with HIV, but when does that change into a research assistant, change into? I am proud to say last year, 2 years ago, for the first time, I became a lead on a research project and became the principal knowledge user. And I think that's because of the mentors. And I think it's very important for people living with HIV to get those mentorships and for researchers not to stick them just on a community board and really give them those leadership positions. Question, Adrian.
Malula Breach. Hi, I'm Adrian Betts, Executive Director, AIDS Committee, Durham Region. Research is key, and it's, but somehow stigma still slides in sometimes. I just want to mention the fact that research for the sake of research is insulting and degrades us. So finding out whether PHAs prefer blue or red, dumb question. Give us something that actually will affect our lives. Then some groups over-researched. I run a program for positive youth across Ontario, and we had to stop inviting researchers to come to the Hype Summit because youth started to feel like guinea pigs. Be mindful when you go back to the same well over and over again, the impact it can have on people, and then what Muba just said, sometimes seeing the same names as co-investigators, if they look like me, middle-aged gay white men, and that's the only people who are the co-investigators, that's a real problem. So I know you're all, not everyone is like this. Many of you are wonderful, brilliant people, but those of you who are coming up, just be mindful that stigma can be microaggressions too. That's all. Thank you all so much. And the 4-H Club, yes.
Thank you. Chantal.
Good afternoon, everybody. Thank you so much for giving me a voice. So my name is Chantal Mukandoli, and I come from Toronto. So I'm here is not to give a question. I wanted to give the comment. So I'm a community member. I'm a volunteer. I'm a peer. Really, stigma is still around in our communities. If we really be stigmatized, we never understand what it means, the really stigma. This is a true stories. I was stigmatized back home, and they come in Canada. I didn't know here in Canada there is a stigma, because I didn't know even if there is a people living with HIV in Canada. But I was stigmatized in a hospital. So, for me, to be stigmatized is not a problem because I know how to fight about that. And then how to move on and the fight about the stigma discrimination for all the communities without think about the color of the skin, the education, religion, or culture, or sex orientation. One thing just I wanted to say, for me I will say education, level of education. I want to say there was this university without a wallet. It was good for people to increase their education and to do something around the community and they practice the JIPA and the MIPA principle. So I want just to ask, I know some of the policymakers, they are here, doctors, scientists, service providers, some community members. What I wanted to ask is really to have this funding around our communities for people living HIV, to go to school. Because this community certificate cannot allow you to have a good job and to make a better life as a people living HIV. We are tired to be in the ODSP. We need to go out of that. Please help us to have a funding around the community to go back to school and then to have better life. Thank you so much.
Our final question.
So my question focuses a little bit more on after the research is done. In terms of knowledge translation, what are your hopes for getting it outside of HIV circles, outside of this conference? A lot of the information ends up at the ASOs, the sexual health centers, the members of the community who are interested, but not so much the educational institutions like universities, not so much the professional colleges for doctors, nurses, pharmacists, social workers. What are your hopes for how to get this information outside of the people who will already get it anyway?
Well, I think for me, starting with when we are taking it outside of these circles, there has to be explanation. There has to be some background. I was even looking at the Slido, and somebody had asked, what does JIPA, MIPA mean? And I realized, like, now in this sector, we use so many acronyms, we forget to always break them down. And so giving that explanation, I was talking to somebody who had used the term mother-to-child transmission, and I explained to them that we're not doing that anymore. It's going to be vertical transmission. And they had asked, oh, where did that come from? What does vertical mean? And I didn't even really know the answer, how it turned to that. I just knew we weren't using the other term. And so I think we need to do these explanations in order to explain why we're using the language that we are. And our language has to be appropriate so that we're not going into these outside spaces and giving this information that further stigmatizes people living with HIV, because we've seen that before, and we're hoping to not see that again. Any other comments regarding that?
Well, I think it is a challenge. I think it is a challenge to get beyond the sphere, and how do we make sure that people get engaged in what we're doing? And you know, we continually fight at the level of the medical school, for example, as how much time of their curriculum do they get with HIV is very small. But you know, we've continued to push on that. We've tried to bring the community voice to that as well, to try and improve that education. But I think you're quite right. I think there's a huge challenge in that we are all responsible for making sure that what we do and what we produce as research is generalizable beyond this room.
I think too, just to speak on that, getting that information out there, it's a lot of people, they're still scared to put the information out there because that stigma is still there. And so one thing that comes to mind is that we hear people say, I'm against stigma, but the people that are saying that, really check yourself. I know a lot of people are, but are you saying it and believing that? Or are you saying it because that's what other people are saying? I think I see it, somebody say, stigma and discrimination drives me crazy, but then they turn around and they stigmatize for it again. So if people are saying it, they need to mean it.
Absolutely. And most importantly, this conversation doesn't just end there. This was just kind of a starter course, and please continue having these conversations and discussions. Reach out to any of us. And again, on the Slido app, you can leave your contact information to get more of the information and more of the results that we got. Thank you all for participating. We really appreciate it, and thank you for coming to Lunch Symposium. And have a great rest of your CAHR conference. I would like to thank our esteemed panelists, Dr. Lebouché, Claudette Cardinal, Dr. Walmsley, and Dave Miller.
And I would like to congratulate Maluba for being such a wonderful host today and empowering people living with